Today, I'll be talking to you about orofacial pain. International Association for Study of Pain in 1994 defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So essentially, pain can be considered as a subjective symptom. Subjective symptoms means that a symptom which varies from one person to the other, and it can vary from time to time also. It is considered as a symptom of a disease process that should be diagnosed and treated. Often, cause and effect relationship cannot be established as far as pain is concerned, especially chronic pain is concerned. Bio-behavioral, biopsychosocial model of pain. When I talk about bio-behavioral, biopsychosocial model of pain, we have to think of a situation where you have to have a model for studying pain. There should be some theory and some basis on which we are explaining a painful situation. And the present model for pain is called the bio-behavioral or biopsychosocial model of pain. And as the name suggests, there are various factors that influence pain, which includes physical, psychological, and social factors. Physical factors essentially means that anatomical, structural, and molecular factors that cause orofacial pain. When you talk about the psychological system, it is actually the motivation and the personality on the experience of illness and reaction to disease that describes the pain. The social systems that influence pain is cultural, environmental, and also familial systems that influence the expression and experience of an illness. So essentially, now pain is modeled on bio-behavioral or biopsychosocial model of pain. Anatomical considerations in pain includes the anatomy of pain stimulation, pain modulation, pain conduction, and perception of pain. So anatomical structures that are involved in all these aspects are considered under anatomical considerations of pain. So essentially, we start off with nociceptors. Nociceptors are receptors that are activated by intense noxious stimuli. And actually, in nociceptors, they encode the intensity, duration, and the quality of the stimulation of nociceptors. And all these, that is intensity, duration, and quality of stimulation, is in turn converted into signals that may probably qualitatively and quantitatively define a painful stimulus. The type of nociceptors are essentially two types. That is unimodal. Unimodal means they either transmit thermal stimuli or transmit mechanical stimuli. Polymodal receptors can transmit all type of stimuli, that is mechanical, thermal, and chemical stimuli. Essentially, the impulses which are generated in the nociceptors are transmitted along A delta fibers and unmyelinated C fibers. Unmyelinated C fibers are slow and small diameter axons. Now let us have a look at the different type of nerve fibers, because we have to learn about the different type of nerve fibers when you talk about conduction of orofacial pain. We have essentially three types of fibers, that is A fibers, B fibers, and unmyelinated C fibers. A fibers are further classified into A alpha, A beta and A delta fibers. B fibers are actually preganglionic autonomic fibers, and unmyelinated C fibers are slow, small diameter axons. There is no myelin sheath involved in this. So A alpha, A beta fibers are large fibers, but mostly these two are involved in inhibitory activities. So as I said before, the nerve fibers that transmit pain are usually A delta fibers and unmyelinated C fibers. This is a picture of the pain pathway, which starts from the nociceptors in the orofacial region, and it is transmitted along the trigeminal nerve to the trigeminal ganglion. From the trigeminal ganglion, it is transmitted along the spinal tract of the trigeminal nerve and reaches the spinal nucleus of the trigeminal nerve. From the trigeminal nucleus of the trigeminal nerve, it reaches the nucleus caudalis. And from the nucleus caudalis, it crosses over to the other side, and from there, it ascends to the midbrain. And in the midbrain and the thalamus, it fans out, or the fibers fans out into the primary sensory neural cortex. Acute pain. Let us have a look at what acute pain is all about. Acute pain is warning of an actual or a potential tissue damage, and it describes the protective aspect of pain. The characteristic feature of acute pain is that it is very short in duration. Acute pain cannot prolong for a very long period of time. Whereas chronic pain is that pain that persists even after the normal period of time, healing is over. That is, an injury has happened and there is a nerve damage or whatever problem has happened. There is organic defect which is present over there. Normally, at that particular point of time, there will be acute pain. Immediately following that, the healing process takes place. So now, when the healing process takes place, we expect that there is definitely a reduction in the painful stimuli. Sometimes, when chronic pain is involved, the healing will take place. Normal healing has happened. Organic defect has healed, but chronic pain remains, or pain remains. So now it is called as chronic pain. The moment you start calling pain as chronic pain, you have to specify the time for which it has been lasting. Earlier, the time frame for classifying a painful stimuli as chronic pain was 6 months. Now it has been reduced to 3 months. So essentially, it has another side to this statement. That is, whenever you are taking a case history regarding a painful stimuli in the orofacial region, whenever you are dealing with a patient who is in pain, you have to take a history of minimum of 3 months. Otherwise, your history will remain incomplete. So a pain that lasts longer than 3 months is considered to be chronic. IASP definition of chronic pain is that a persistent pain that is not amenable as a rule to treatments based on specific remedies or to the routine. It essentially means that a pain which does not respond to routine treatment options. It does not respond to routine remedies or specific remedies that is intended for treatment of a particular disease process. So as I said before, Bonica in 1953 has suggested that chronic pain is a pain that persists past the normal time of healing. So now let us have a look at, we were dealing with the biopsychosocial model of pain, which, as I said before, involves the biologic aspect or the anatomical aspect, psychological aspect, and the social factors that influence pain. So in this slide, I have enumerated the psychological factors that influence chronic pain. The first factor is emotion, then psychological distress, family and work environment, cultural background, what it means, what a painful stimuli means to you or to the patient, and the appraisals regarding the controllability of pain. So all these are psychological factors that include chronic pain. Emotion, as you know, the emotional state at which the patient is in when he or she is undergoing a painful stimuli. Psychological distress is if the patient is in psychological distress, definitely even minor stimuli, which is usually not considered painful, can be perceived as a painful stimuli. So that is the role of psychological distress in pain perception. Family and work environment also consists of makes family and work environment also plays a very important role in influencing chronic pain. Cultural background, definitely, because if you live in a cultural background where pain is explicitly expressed, then you will definitely, the expression of pain will be much more than what you are expecting. Especially when you deal with the persons who want to justify their suffering of pain. They will definitely over express pain and they will create some kind of drama, which is definitely a consideration of expression of pain. Appraisals regarding controllability of pain. That is, if you tell the patient that, see, your painful stimuli, I agree that it is existing and it is okay. And at the same time, I have certain remedies which may work in your case. And let us try all these things one by one. Even when you tell them that this remedy is available, patients can have some kind of hope that will regarding the controllability of pain, and that itself can influence the chronic painful stimuli. Chronic pain usually follows a peripheral or a tissue injury. That is the first step. Then what happens? The tissue injury leads to a pathological state and it can start developing. This pathological state can lead to persistent pain. Up to that part, everything is okay. But now, once the injury happens, the body will try to heal that injury. When the healing is taking place, or while the healing is taking place, normally we expect the painful stimuli or the intensity of pain to come down. But in case of chronic pain, that does not happen. And the pain starts persisting even after the healing of the injured tissue. So when you see that the pain is persisting even after the healing of injured tissue and there is no organic defect any longer existing in that particular site, then you have to be alerted to the fact that the pain is no longer a warning signal, but a disorder in itself. Pain is the problem. As I said before, if you think of acute pain can always be indicative of actual or a potential tissue damage. But here, in chronic pain, damage has occurred, pain has started, but after pain has started, then healing has happened. And once healing has happened, there is no organic defect existing at that particular point any longer. When there is no organic defect existing at that particular point, if the pain is still persisting, then pain is the problem and it is no longer protective in nature. Then you classify that pain as chronic pain. There are different types of pain mechanisms involved. it started with specificity theory. Specificity theory means that the pain is a very specific sensation. It involves the anatomical network of receptors, nerves, and tracts. And actually, in the stimuli that is transmitted through these anatomical network of receptors, nerves, and tracts, it is relayed in brain that deals exclusively with neural information regarding noxious stimuli. So it essentially means that a particular nerve fiber is activated only by a chemical stimuli. Another type of nerve fiber is activated only by physical stimuli, like, for example, pressure sensations. And another type of muscles of nerve fibers are activated only by temperature. Likewise, you have a specific receptor and an anatomical network of nerves and tracts which deals with very specific natures of pain. That is whether it is pressure, temperature, and acute pain and all that stuff. But this could not explain so many features of pain and so many disease processes. So that was dumped, and the second theory came into being, that is the intensive or summation theory, which essentially means that there is an anatomical network of receptors, nerves, and tracts, but these can transmit any of these painful stimuli, which starts from pressure sensations to really painful sensations. But depending on the intensity of the stimulation, you can either have pressure, simple pressure at one end, to intense pain at the other end of the spectrum. That is, if the stimulation is adding to one another, there is gradual buildup of intensity of pain, and pain can vary from pressure sensations to very severe type of pain. So that is one theory. That also could not explain all aspects of pain. So they dumped that theory, and again another theory was proposed, that is the pattern theory. Pattern theory essentially means that again you have the normal network of or anatomical network of receptors, nerves, and tracts. But these network of receptors, nerves, and tracts should be stimulated in a particular manner, in a pattern, to create pressure. Another pattern is required to create a temperature response. Another pattern is required to create a really painful response. So pattern theory used to be the theory that is involved. But in 1965, Melsack and Wall introduced the gate control theory, and gate control theory is a theory that is even now accepted as the theory of the pain mechanism. So gate control theory is the theory that is proposed by Melsack and Wall in 1965 and is still the accepted theory regarding pain generation, transmission, and perception. As you can see in this picture, you have a series of activities that occur along with a painful stimuli. And this gate control theory can definitely address the perceptive and affective component of pain, and also to a large extent the reaction to pain. This theory is successful enough to explain the visceral changes that happen when there is a painful stimuli. So this particular picture explains the gate control theory of Melsack. This is a picture that I had made, so it is not available in most of the textbooks. A different version of this may be available in the textbook. You can take a note of this particular gate control theory of Melsack and Wall. So now let us have a look at the behavioral issues related to chronic orofacial pain. Pain behavior and disability is very important, as important as the pathophysiology of pain. And pain is definitely influenced by social environment. So now these statements indicate that pain, stress, and depression are interrelated. Now let us have a look at how these things are interrelated. Pain and consequences of pain are stressors. They can induce stress in an individual. The second point which is important is that emotional distress is a component, consequence, as well as a cause of pain. It means that if you are emotionally distressed, then therefore it can definitely modify pain. It can be the result of pain, and also it can be the cause of pain. Similarly, prevalence of depression in chronic pain patients has been found to be very high. That is, evidence shows that prevalence of depression in chronic pain patients is very high. So now the theories have been proposed to explain the three processes, that is the relationships between pain, stress, and depression. The theories proposed to explain these three processes indicate that depression causes increased sensitivity to pain, and pain is a master form of depression. Depression can be caused by the stress of chronic pain, and depression, anxiety, and anger frequently coexist. So essentially, because of these facts, literature suggests that pain is more likely to cause emotional disturbance than to be precipitated by them. That is, it is the painful stimuli that occurs first most of the time, and that will slowly build up into an emotional disturbance rather than the other way around. That is, emotional disturbance leading to pain, chronic pain. Most of the time it happens like that. That is, pain starts first, then likely emotional or behavioral issues related to orofacial pain follows. So when you talk about behavioral issues, you have to talk about dysfunctional pain. So what is dysfunctional pain? Dysfunctional pain is the name given to pain with very high levels of pain severity. And there is affective distress. Affective distress means that the patients in pain will have the pain interfering with daily life activities. Along with that, the patient will start thinking that the control or the patient's control over daily life activities is lower than normal. Patient who is in a habit of walking about a kilometer or so would think twice or 10 times before embarking on a walk. A patient who is in the habit of visiting a particular location every day, or rather on alternate days, will think 10 times before embarking on that activity which he or she used to do as a routine procedure. So essentially, there is an affective distress with interference with life activities. There is increased stress because of this. All these will result in the patient seeking relief from pain. So how does he or she get relief from pain? By using medical services in the form of medication, in the form of physiotherapy, in the form of medical consultations. Likewise. So excessive use of medical services, patients may not get relief from a particular source or a single source, and because of that they will keep changing medical services or medical resources. like hospitalizations, and even it can lead to medical abuse, that is over usage of medication. So that is the characteristic of dysfunctional pain. So when you see any of these characteristics in a person, then you have to think of pain being of a dysfunctional nature. With that, we come to the end of an introduction to pain, especially chronic orofacial pain. In the next topic, we will deal with examination and assessment of patient with chronic orofacial pain.